Hello everyone, my name is Hongchae Baek. Thank you for joining me. Today I'd like to talk about feasibility of accelerometer measurements for real-time monitoring of patients' treatment during MR-guided focus ultrasound. MR-guided focus ultrasound thalamotomy is incisionless neurosurgery, and the great advantage of MRgFUS is that the ablation is performed through an intact skull. The ability to perform awake surgery with patients performing multiple tremor tests allows for optimizing the therapeutic target and reducing adverse events. Intraoperative quantification of tremor using accelerometry allows near real-time objective assessment of tremor severity. The objective of this study is to show the feasibility of intraoperative quantification of tremor severity using accelerometry. 18 tremor patients consented to both accelerometry and MRgFUS. Before the treatment in the holding room, MR-compatible accelerometer sensors were strapped on patients' finger, forearm, and arm of the affected limb. We simultaneously measured tremor motion using accelerometry during intraoperative testing. The joint angle measured using the accelerometers quantified differential changes in the tremor severity at the shoulder, elbow, and the wrist. These two graphs show the intraoperative quantification of tremor throughout the multiple sonications. The changes in the joint angle measurements show that MRgFUS reduced the tremor in upper extremity for both postural and kinetic tremor tests. In the postural tremor test, on average, the final sonication induced 85% joint angle reduction. And in the kinetic tremor test, on average, the final sonication induced about 75% of joint angle reduction. We found that qualitative assessment of patients' drawings correspond with accelerometer angle measurements. Here are the 8 intraoperative drawings from 1 PD patients, including the baseline, and the below graph shows that the percent change of joint angle measured during the patient's signature, spiral, and line drawings. And the table shows the average scores of signature, spiral, and line drawings from 3 independent evaluators performed in a blinded fashion. The patient's signature at the top started looking legible after the 6th sonication, which coincided with significant angle reduction from the 6th sonication. The patient's spiral drawing began to show complete circular form after the 5th sonication, which coincided with substantial joint angle reduction in spiral drawing from the 5th sonication. Finally, the patient began to draw relatively straight lines after the 4th sonication, which corresponded with a significant joint angle reduction at the 4th sonication in line drawings. Furthermore, for a more comprehensive clinical correlation assessment, we scored 92 drawings from 14 patients on a scale from 1 to 10, 10 being the best. We found a strong negative correlation between the qualitative scores and the accelerometer measurements of the wrist angle for each signature, spiral, and line drawing, indicating wrist angle measured during the handwriting tends to become smaller as the drawing score increases. We also found that the positional change influenced the tremor measurements. We compared the joint angle in the supine position when measured during the patient was lying down on the MRI bed and when sitting upright. The postural tremor was diminished in the supine position when measured after the treatment. In contrast, the supine position enhanced the kinetic tremor at the baseline. An additional difference between ET and PD group was observed for the kinetic tremor with positional changes. In the PD group, significant wrist angle improvement were observed only in patients' supine position. In contrast, ET patients showed significant wrist angle improvement regardless of their position. This finding shows that kinetic tremor assessment using accelerometry could help us identify and confirm the etiology of the tremor. Lastly, I'd like to show the potential utility of assessing accelerometer measured tremor in target adjustment. Both axial and coronal somatotopy of thalamus are shown in the left. In the middle, you can see the intraoperative T2 weighted images, which was obtained after having 2 consecutive sonications above the ablative level to confirm the lesion size and location. The lesion focus, marked with green, was at the border of VOP and VIM when fused the T2 image with brain lab autosegmentation of the thalamic structure. So we move the target at the final sonication in the posterior direction to navigate to the shoulder and the elbow region marked with blue and red in reference to axial somatotopy. We achieved an average 92% improvement in the overall upper extremity at the end. In the second case, we adjusted the target laterally first, as the patient reported tingling in the tongue after the second sonication, to move away from the tongue region according to the coronal somatotopy. Then we adjusted target in the anterior direction to further suppress the elbow and shoulder tremor according to the axial somatotopy, but there was no change in improvement. Finally, we made a final adjustment in the superior direction to locate the elbow and shoulder according to the coronal somatotopy, which further suppressed the elbow angle up to 90% compared to the baseline. This study evaluated the validity of using intraoperative accelerometry in tremor patients during MRgFUS. The angle measurement during kinetic tremor testing were highly correlated with qualitative data. Patient's position did influence the tremor measurement. The supine position enhanced the kinetic tremor severity at the baseline in PD. Target adjustment for the optimal therapeutic outcome is a 3-dimensional challenge, and further investigation is needed to validate the use of accelerometer to refine the coordinates in attempt to improve the treatment effectiveness. Thank you to the listed people for their support. And if you have any questions, I'll be happy to answer them during the Q&A.